Imagine you're going to a specialized clinic.
Mm.
You're dealing with some really deeply personal, like incredibly frustrating symptoms.
Right, the kind of things that just drain you.
Exactly. Vaginal laxity, this persistent feeling of looseness, maybe some urinary leakage, just discomfort that is really impacting your quality of life.
Mm-hmm.
So you sit down with a specialist, you're ready to discuss treatments, maybe some advanced laser therapy you've been reading about online. And the very first thing the doctor asks you is, tell me about your lungs. Do you have a chronic cough?
It just sounds completely disconnected, like you're sitting there for pelvic floor health and they are asking for a respiratory history.
It sounds totally absurd, like going to the dentist and having them examine your kneecaps or something. But
Yeah.
as it turns out, that question about your lungs represents the absolute cutting edge of comprehensive pelvic care.
It really does. It's fascinating.
So, welcome to today's deep dive. We have this massive stack of medical sources to unpack today. Clinical guidelines from the NHS, the American College of Obstetricians and Gynecologists, and some truly wild cellular research.
Yeah, the cellular level stuff is incredible.
It is. And we're exploring all of this: pelvic floor health, the genitourinary syndrome of menopause, and the highly debated world of vaginal rejuvenation. And we are doing all of this to answer one very specific, vital question for you.
Which is, should a chronic cough be treated before you undergo vaginal laxity treatment?
Exactly. So to really get to the bottom of that question, I feel like we have to completely change how we visualize the human body.
Right, we do. We really need to stop seeing the chest, the hormonal system, and the pelvic floor as these like isolated compartments. Because what is happening in your airways is mechanically and microscopically reshaping the connective tissues at the very base of your torso.
Okay, before we can even touch on lasers or cutting-edge treatments, I really want to understand the physical forces at play here. The sources keep bringing up this term, the pressure stack. What are we actually talking about when we say that?
Well, think of the pelvic floor as this dynamic load-bearing hammock made of muscle, ligament, and fascia.
Okay, a hammock.
Right? It sits at the very bottom of your pelvis, and its primary job is to support the bladder, the bowel, and the uterus. So it is constantly working against gravity.
That sounds exhausting for those muscles.
It is, but it's also working against intra-abdominal pressure. Every single time you move, that pressure changes.
So the stack refers to everything compounding that downward pressure.
Exactly, that's the concept.
Yeah.
The pressure stack is this combination of factors that continuously force pressure downwards onto that anatomical hammock. So we are looking at things like chronic constipation, where constant straining becomes a daily habit.
Oh, wow.
And heavy lifting is another massive factor, whether that's weightlifting at the gym or just working a demanding physical job. Obesity adds a constant static weight, too. And then central to our focus today, there is the chronic cough.
Like a smoker's cough or severe asthma or maybe chronic bronchitis.
Yeah, exactly those. And the clinical literature makes a very important distinction here. Your pelvic floor is designed to handle a single cough perfectly fine.
Right, like if I just clear my throat.
Exactly. The system can absorb sudden, isolated spikes in pressure without any issue. The real problem is a repeated, relentless pattern of pressure that the pelvic floor has to absorb over and over and over again, sometimes for months or even years.
Wait, let me try to picture the mechanics of this. Is it kind of like a trampoline?
Oh, a trampoline. Yeah, go with that.
Like if I go out in the backyard and jump on a trampoline normally, it's fine. The springs stretch, they bounce back. But if I decide to jump on that exact same trampoline wearing heavy lead boots, like every single day for 5 years, eventually those springs are going to permanently lose their tension, right?
Mm-hmm.
They're going to get stretched out and totally ruined.
That is a great way to visualize it on a macro level, but the sources actually take us much deeper, like down to the micro level. We need to look at the cells that actually manufacture your springs.
Oh, the literal material making up the trampoline.
Yes. The research dives into these in vitro studies on vaginal fibroblasts.
Fibroblasts.
Right. These are the cells responsible for maintaining the extracellular matrix, specifically collagen, which gives the tissue its strength, and elastin, which provides the recoil.
Okay, I'm with you.
So researchers set up this incredible experiment. They took these vaginal fibroblasts and placed them on a specialized mechanical stretching device.
Wait, they built a tiny stretching rack for cells.
Basically, yes. And they stretched the cells by 10% for 12 hours a day.
12 hours.
12 hours. They were simulating the exact rhythmic, relentless strain of daily upright movement compounded by actions like chronic coughing.
That sounds brutal. What actually happens to a cell when you stretch it like that for 12 hours?
Well, the mechanical stretch literally changed the behavior of the cells. Under that repetitive strain, the fibroblasts started producing significantly higher levels of an enzyme called collagenase.
Which does what exactly?
Specifically, they're called matrix metalloproteinases, or MMPs, and these are enzymes that actively degrade and break down collagen.
Hold on, I'm a little confused here.
Hmm.
Because when I go to the gym and lift weights, I'm putting mechanical stress on my body, right?
Right.
But my muscles adapt. They get stronger and build up. Why does this repeated stretching from coughing make the vaginal connective tissue weaker? Why is it actively degrading itself instead of building up like a bicep?
It's a great question, but muscle tissue and connective tissue respond to mechanical stress through completely different mechanisms.
Oh, they do.
Yeah. Skeletal muscle has a rich blood supply and relies on specific satellite cells designed for hypertrophy. Like, the muscle fibers tear slightly and then rebuild thicker.
Okay, that makes sense.
But the connective tissue in the vaginal wall relies on those fibroblasts. Under normal physiological loads, fibroblasts do their job. They maintain and build collagen.
Right.
But under excessive, repetitive, non-physiological stretch, like the sheer force of a chronic cough, the mechanoreceptors on the cells trigger a stress response.
Yeah?
Instead of building, they release those collagen-degrading enzymes.
Wow.
So the more the tissue stretches, the more it literally dissolves its own structural support.
That is wild. The trampoline isn't just losing its bounce because the springs are tired. The springs are actively dissolving themselves because of the constant pounding.
Exactly. The collagen is being broken down much, much faster than the body can possibly replace it.
But I mean, people cough all the time. People get terrible respiratory infections. People have bad seasonal allergies. If mechanical stretching degrades collagen that aggressively, why doesn't every single person who gets a bad winter flu end up with severe permanent pelvic floor prolapse?
Because the human body has a built-in defense mechanism against this specific type of mechanical degradation.
Oh, thank goodness.
However, for a massive portion of the population, that defense mechanism disappears over time.
Okay, we're talking about the drop in estrogen during menopause, aren't we?
We are. During the reproductive years, estrogen acts as this powerful protective shield for these tissues. You'll see the sources frequently refer to GSM.
GSM, that's the genitourinary syndrome of menopause. I noticed that term. It seems to replace the older term vulvovaginal atrophy, right?
It has, yeah. It's a much more comprehensive term because it acknowledges that an entire ecosystem is essentially collapsing. When estrogen drops, the superficial epithelial cells aren't renewing.
Okay.
Glycogen levels plummet, which then starves the good lactobacilli bacteria. That shifts the vaginal pH, making the whole environment more alkaline and prone to infection.
Wow, it's a huge domino effect.
It really is.
Yeah.
But specifically for our structural conversation today, the absence of estrogen means a massive loss of collagen and tissue moisture.
Since we know estrogen drops during menopause, how does that factor into the physical stretching experiment we were just talking about?
So the researchers who did the stretching experiment actually took it a step further. They ran the exact same mechanical stretching protocol, the 12 hours of relentless 10% strain.
The cell stretching rack.
Yes, the cell rack. But this time, they bathed the fibroblasts in 17-beta-estradiol.
Which is a type of estrogen.
Right, a highly active type. And the results were stunning. In the presence of estrogen, the stretch-induced breakdown of collagen was suppressed entirely back to baseline levels.
Wait, really? You're saying the estrogen stopped the cells from destroying their own collagen even while they were being continuously stretched?
Yes, it completely blocked the overproduction of those collagen-destroying enzymes. It protected the cell's shape and their internal architecture. Estrogen actively defends the tissue from everyday mechanical damage.
So, going back to my trampoline, estrogen is essentially the rust-proofing on the springs.
I like that, yes.
As long as it's there, you can jump all you want. But once menopause hits and that rust-proofing wears off, the springs become incredibly vulnerable. Suddenly, every single cough is doing permanent microscopic damage.
When estrogen is gone, the tissue isn't just thinner. It is actively being degraded at an accelerated rate by the normal physical strains of daily life.
Okay, but if estrogen is this incredible magic shield, this raises a very obvious question for me.
Which is?
Why is there a massive booming industry of expensive lasers and surgeries for vaginal laxity? Why wouldn't a doctor just prescribe a topical estrogen cream, reapply the rust-proofing, and call it a day?
Well, there are two major roadblocks to that. First, estrogen simply isn't an option for everyone.
Like who?
For patients who are breast cancer survivors, particularly those on specific hormone-blocking therapies, estrogen creams are often strictly contraindicated. Introducing any estrogen, even topically, is a risk their oncologists just won't allow.
Oh, of course. That makes complete sense. But what about patients who can safely take it? Why are they looking at lasers?
The second issue is that while estrogen is fantastic at preventing further degradation and improving surface moisture, it cannot always reverse severe, long-standing structural damage.
Oh, I see.
Right. So if the deeper collagen matrix has already been severely compromised by, say, a decade of chronic coughing, past childbirth trauma, and aging topical estrogen alone might not be enough to rebuild the foundational architecture of the vaginal wall.
So if estrogen isn't a silver bullet for everyone, patients are going to look for other options. Is that why we're seeing this massive explosion of tech treatments in the pelvic health space?
Absolutely. The market has just flooded with energy-based devices, or EBDs. You will hear about fractional CO2 lasers marketed under brand names like Mona Lisa Touch or FemTouch and various radiofrequency devices.
I have to admit, the idea of using a laser inside the vagina sounds a bit like science fiction. How are they actually supposed to fix laxity?
The core mechanism of these devices relies entirely on controlled trauma.
Controlled trauma.
Yeah. A fractional CO2 laser, for instance, uses a specialized probe to deliver light energy deep into the vaginal wall. This creates thousands of microscopic thermal injuries.
Thermal injuries, like burns.
Yes, tiny intentional burns or lesions in the mucosa.
Hold on, I really want to push back on this. We just spent the entire first half of this deep dive talking about how we want to stop damage to the tissue. The tissue is already compromised, thinning, and lacking moisture because of menopause. And the proposed high-tech solution is to burn microscopic holes in it.
I know how it sounds.
It sounds like microneedling for your face,
Yeah.
but in a highly sensitive, already vulnerable area. Is that actually safe?
Well, that is the exact debate raging at the highest levels of the medical community right now.
Right.
Yes. The theory driving the industry is that by creating these controlled microlesions, you force the body's natural healing response into overdrive. It intentionally stimulates the fibroblasts to produce a massive surge of new collagen and new blood vessels. The medical term is neocollagenesis.
So tricking the body into healing itself.
Right. The ultimate goal is to remodel the tissue, forcing it to become thicker, tighter, and more elastic.
I understand the theory, but what do the regulatory bodies say? Are they on board with this?
Not at all. We have very clear, strong warnings from the FDA and the American College of Obstetricians and Gynecologists, ACOG. They state firmly that vaginal rejuvenation is a marketing term, not a medical one.
But these devices are in clinics everywhere. I've seen the ads. How are they operating if the FDA is warning against them?
It comes down to how medical devices are cleared in the U.S. These lasers are FDA cleared for general surgical applications, things like destroying abnormal cervical tissue or removing warts.
Oh, so they just use them off-label for rejuvenation.
Exactly. They have not been explicitly approved for the specific indication of treating vaginal laxity or menopausal symptoms, and the FDA has warned of serious adverse events associated with using them for rejuvenation.
Like what kind of adverse events?
Things like severe vaginal burns, scarring, pain during intercourse, and chronic pain. They argue the rigorous long-term safety data simply isn't there yet to justify widespread cosmetic use.
So the FDA is essentially flashing a giant red light. Yet clinics are marketing it as a cure-all. How are you supposed to navigate that as a patient? Especially when you look at the other side of the sources we have, because there are clinical pilot studies, retrospective reviews, and patient testimonials reporting incredible, life-changing results.
The gap between regulatory caution and patient experience is vast right now. The literature includes pilot studies showing that after a course of, say, 3 laser treatments, postmenopausal women reported highly significant subjective improvements.
Like actual relief from their symptoms.
Yes, major reductions in vaginal dryness, significant relief from dyspareunia, which is painful sex, and noticeable, measurable improvements in their vaginal health index scores.
Wow.
Some studies even point to relief from mild stress, urinary incontinence.
It's the classic medical frontier. You have patients desperate for relief who are experiencing real benefits in these smaller trials, while the regulatory bodies are demanding massive, long-term safety data before they'll endorse it.
Exactly. And the innovation isn't just stopping at thermal lasers. The sources also highlight emerging regenerative therapies that don't rely on injury at all.
Oh, no burning involved.
Right. For instance, there are clinical explorations into injecting type I collagen. There's a product called MD Tissue directly into the vulvovaginal area.
Wait, injecting collagen directly? Like getting lip fillers, but for the pelvic floor.
Conceptually, it's very similar. But the mechanism is different than the lasers. Instead of burning the tissue to force the body to scramble and create its own collagen, the injected collagen acts as an immediate mechanical scaffold.
Oh, so it just supports the tissue right away.
Yes, it provides instant structural support, improving tissue turgor and hydration. Early data shows it successfully dropping severe GSM symptoms down to mild levels without the thermal trauma.
Okay, this is all fascinating, but let's bring this all back to the central focus of our deep dive today.
Yeah.
We have all these high-tech, expensive, and sometimes experimental therapies aiming to rebuild the collagen in the pelvic floor. If you were a patient considering investing the time, the thousands of dollars, and accepting the potential risks of a laser treatment to rebuild your vaginal collagen, does it make any sense to do that if you were still hacking up a lung every morning?
To answer the focus question definitively, yes. A chronic cough absolutely must be addressed before, or at the very least alongside, any vaginal laxity treatment. It is an absolute prerequisite for long-term success.
Because what happens if a patient ignores the cough and just gets the laser treatment anyway?
Well, let's trace the physics back to where we started. If you spend that money and undergo a laser treatment, you are intentionally traumatizing the tissue to stimulate your fibroblasts.
Right.
They work overtime to create brand new, healthy collagen. You're building a new support structure. But if you walk out of that clinic and continue to have a severe, unmanaged chronic cough, every single time you cough, you are slamming downward intra-abdominal pressure directly onto that brand new collagen.
Oh man, I see it. You're jumping on the brand new trampoline springs with the lead boots again.
Exactly. The repetitive mechanical stretch from the cough will trigger those mechanoreceptors all over again. The fibroblasts will release collagenase, and they will actively degrade the very collagen you just paid thousands of dollars to build.
Wow.
You are setting yourself up for inevitable failure.
So getting an expensive laser treatment while you still have an unmanaged smoker's cough. It's like renovating your living room, putting down beautiful, expensive new hardwood floors while there's still a massive hole in your roof.
That's a perfect way to put it.
Like, why would you fix the floorboards if you were just going to let it rain on them again the very next day?
You have to fix the roof first. You must stop the source of the chronic mechanical damage. This is why the NHS and the Royal College of Obstetricians and Gynecologists explicitly list managing a chronic cough, whether from smoking, asthma, or bronchitis, as a foundational, non-negotiable part of pelvic organ prolapse and laxity care.
It's treating the whole system. The lungs are literally dictating the pressure on the pelvis.
Treating the asthma or quitting smoking to reduce the cough are literal mechanical interventions for the pelvic floor.
Now, obviously, some coughs can't just be cured overnight with a pill. If someone has a chronic respiratory condition like COPD, they're going to cough. Do the clinical guidelines offer any practical advice on how to protect the pelvic floor when a cough is unavoidable?
They do, actually. And it involves a technique that is beautifully simple in concept but requires practice. The physical therapy guidelines in our sources refer to it as the knack.
The knack. That sounds catchy. What exactly does that entail?
It is a precise, consciously timed muscular contraction. The goal is to actively lift your pelvic floor muscles, pulling them up internally from the tailbone toward the pubic bone, just before you cough, sneeze, or lift something heavy.
So the focus is on the timing of the flex, not just how strong the muscles are overall.
The timing is everything. You are manually bracing the hammock right before the heavy weight hits it. By contracting the muscles a split second before the abdominal pressure spikes, you physically support the bladder neck and prevent the connective tissue from taking the full, tearing force of the stretch.
That makes sense, but how do you train your body to do that automatically? I imagine it's pretty hard to remember to flex right as you feel a sneeze coming on.
It is hard at first. The guidelines recommend practicing this actively to build the neural pathway. They suggest doing 10 fast lifts and 10 slow holds 3 times a day.
Okay, 10 fast, 10 slow.
Right. The goal is muscle memory, so that bracing before a cough eventually becomes a subconscious automatic reflex rather than something you have to frantically think about.
That is incredibly practical, actionable advice from the literature. So what does this all mean for you listening? I think the biggest takeaway here is the realization that pelvic health is not just a gynecological issue. It is profoundly, undeniably interconnected.
Absolutely.
It is respiratory. Your lungs dictate the physical pressure.
Wow.
It is hormonal. Your estrogen levels dictate the resilience of the cellular tissue. And it is mechanical. The physics of how you move, lift, and cough dictate the daily wear and tear.
Yeah.
You can't just treat one part of the body in isolation and expect a miracle cure.
It's a true marvel of biological engineering. And if we connect this specific relationship to the broader picture of human anatomy, it leaves us with something quite profound to think about.
Yeah.
We have just explored how something as common and seemingly disconnected as a chronic cough can literally microscopically remodel your internal pelvic anatomy over time through sheer mechanical force.
It fundamentally changes the shape and behavior of the cells.
Right? It alters the very structure of your tissues,
Yeah.
and it really makes you wonder if a simple cough can systematically dissolve the connective tissue in the pelvic floor. What other seemingly harmless, everyday physical habits, like the way we sit at our desks, the way we breathe, the way we carry tension in our shoulders, are quietly, fundamentally reshaping the connective tissues in other parts of your body right now?
Man, that is a wild thought. Think about that the next time you clear your throat. Thanks for joining us on this deep dive. We'll catch you next time.